Good morning. Black coffee this morning. I'm getting used to it. I'm on the ketogenic diet and intermittent fasting, trying to overcome the effects of middle age spread. Or, as somebody said the other day to me, the COVID-15. So, anyway, today I wanted to give my speech therapist audience love. By the way, if you're a speech therapist, and you watch my channel, will you comment below? Sometimes I feel like I'm just speaking to PTs and OTs, and I don't have anybody following me as a speech therapist. So I wanted to get some input. Are there speech therapists actually watching my content? But I want to talk about a speech therapy issue that I see, and I've seen it a lot, but I was reminded of it when I did a chart audit for a private organization last night for a speech therapist that was documenting on a dysphagia patient. Now, this patient had oral phase dysphagia, primarily showing up as pocketing with sometimes a reflexive protective cough going on. I referred to the speech therapist for treatment of that. And one of the things I've seen, not just in that documentation, but documentation by speech therapists as a whole, when it comes to swallow dysfunction, is they'll major in things like focusing on alteration of diet consistency. So we're talking about an external change that'll hopefully positively influence the swallow function. They'll major in that. They'll also major in what's called compensatory strategies, where the patient does things to help them swallow better. In this case, things like lingual sweeps, things like alternating between solids and liquids, things like that. But what I don't see is speech therapists on a regular basis focusing in on true rehabilitation. So, for example, a patient's pocketing, that's caused by something. Now, I'm not going to pretend to know all the issues related to pocketing. I won't pretend at all. But there are things, we call them underlying impairments, that are preventing that proper clearance of the mouth and preventing the pocketing. And if you directly address those things, that would be called rehabilitation. In other words, what I'm not seeing often when I do speech therapy chart review is taking a patient through improvement treatment where they're working on improving the things causing the pocketing. I see a lot of alteration of diets. I see a lot of compensatory strategies. I don't see addressing directly the things causing the problem. So some patients can't rehabilitate. They cannot gain capability in their underlying impairments, like, let's say, tongue strength and range of motion. Let's say it's buccal strength. Okay, those are a couple things I know a little bit about. They can't, some patients. But you as a speech therapist, when you're documenting on a patient that has dysphagia, you owe it to them to, one, objectively identify those things that are preventing a safe swallow. And that's another thing I don't see a lot of. I don't see good objectification. And that is so important. If you're going to track progress, you need to measure. I don't see objectification of that, and then I don't see the rehabilitation. If you're a speech therapist and you evaluate a patient and you determine there's no way they're going to rehabilitate, you should state that. And then you should focus in on learning compensations and modifying diet. And that's it. Now let me harp on that just for a minute. Medicare is a general expectation that when you're doing training related to, let's say, swallow dysfunction or compensatory strategies for transfers or things like that, your frequency and duration of treatments is going to be extremely low. Generally, it's going to be between 2 to 4 visits. You're going to train somebody how to take over that aspect of their own care. In this case, it would have been the patient's wife, because the patient clearly had cognitive dysfunction. I might come back to that. And that wife, we should be determining in this case, Was she willing? Was she able? Was she available? So once those are established and they're not always clearly documented, then you should be in and out fairly quickly if you're not focusing on rehabilitation of the underlying impairments. So you want to make sure as a speech therapist, if you identify swallowing dysfunction, to objectify the key components and then address them specifically from a rehabilitative standpoint. And if that doesn't work, then fine, you move on to compensations, you move on to dietary modifications, etc. But once you get to that point, limited frequency, limited duration of visits, and you're done, you're out. Now let's talk about cognition. One of the problems I saw in this case the other night, which I've seen a lot in the past when I did nothing but chart review, is you should really baseline cognition. If you're doing a swallow treatment, cognition assessment is essential. One of the things that Medicare expects is an understanding of the capability of a patient to learn a new activity. And so if you're not documenting their capability of learning and you're documenting how you're training them in compensatory strategies and they're not learning, which happened in this one case, you have to ask yourself, are you training the right person or are you just spinning your wheels? And I clearly, as I was going through these notes the other night of this one speech therapist who did not assess at all cognitive linguistics, as I went through the chart, I realized this patient was not capable of learning safe compensation techniques for swallow function. And I just gleaned that from looking at the notes. And then it became clear we were wasting a lot of visits, billing for a lot of service that should not have happened. Now, it doesn't mean that cognitively disabled patients cannot improve their underlying impairments. You may be able to do things that help improve tongue strength and range of motion, or buccal muscle strength. That's about the extent of my knowledge there, or labial closure. There might be some things you can do with a cognitively impaired patient that will improve those things and therefore improve their swallow capability. But you have to demonstrate you're addressing those things. So speech therapists, if you are actually watching my channel, please make sure with swallow patients you address all three components. And I highlight those in the ICE model of care. Improve the impairments, which is often neglected in swallow patients. Teach compensation for impairments, and that'll depend on how cognitively capable the patient is. And then effect environmental adaptations. And in this case, I'm going to talk mainly about two. That would be diet modification, and then, of course, addressing caregiver approach to the patient. That will be a well-rounded care plan, and that would demonstrate more skill. Anyway, just my thoughts. Hope you're having a great day. Happy Monday. Take care, and God bless.